Richard Kwok, Staff Scientist for National Institute for Environmental Health Sciences.
Thanks, Chris. So I'm Richard Kwok with the National Institutes for Environmental Health Sciences. It is one of the 26 institutes and centers within the National Institutes of Health, which is the medical research arm of the federal government. Mike had a great presentation in terms of the overall national response team, and Health and Human Services, which is the department that we're under, does participate in the NRT, but unfortunately the National Institute of Health does not. And so we got kind of a late start, so we weren't involved early on, and so a lot of what Mike had mentioned in terms of the response part of the oil spill response and cleanup, a lot of those efforts were aimed at in terms of cleaning up the pollution, and so we are more interested in terms of the public health and the medical impact of those individuals. And so there's a lot of emphasis on the short-term acute effects in terms of wearing personal protective equipment and other things for the worker safety. But then in terms of the long-term chronic health effects, that oftentimes falls into the cracks, I guess. And so we are working actively to try to change that. We're trying to get invited into the NRT and trying to address some of these deficiencies in the program itself to look at human and worker health safety moving forward. And so that's just kind of a little bit of a sidebar in terms of what I'm about to present to you, which is the physical and human health impacts from the oil spills, results from the GuLF study, which was started in 2011. It is designed to be a long-term health study following the Deepwater Horizon disaster. So the objectives of the GuLF study is to assess health effects associated with oil spill response and cleanup following the Deepwater Horizon. So we hypothesized that workers had the greatest opportunity for contact with the oil and the dispersants, the tar balls, the tar patties. And you can see these are just some of the photos of the cleanup and response efforts during the Deepwater Horizon response efforts. And then to investigate biomarkers of adverse biological effect, and then also to create a resource for future collaborative research with scientists and investigators around the world. And so just an overview in terms of the timeline of the Deepwater Horizon. You can see that the explosion occurred on April 20th, 2010, and the cleanup started almost immediately thereafterwards. And BP and EPA had started a very coordinated exposure monitoring event across the entire Gulf region of the impacted areas. But we didn't get started in terms of just even planning a health study until June of that year, when Francis Collins, the director of the National Institutes of Health, announced to Congress that they would contribute $10 million towards a research effort to look at human health effects from the spill. And so we took almost 7 months in terms of getting up off the ground, getting all the approvals and necessary to get into the field. And we started cohort enrollment in March of 2011. And so, as you may or may not know, 90% of the cleanup effort had already finished. Luckily, the well was top capped in July 15th of 2010. And so much of the free-flowing oil had stopped pretty much here. And so by the time we started enrolling individuals, much of the exposure had stopped. And so these are just the different phases of the study. So we telephone enrollment. We went into individuals' homes throughout the Gulf Coast region. In May of that year, we continued calling these individuals for a first follow-up interview in May of 2013. We conducted more in-depth mental health interviews in September through August of 2013, through August 2016. We brought them into clinics to study them more closely and to look at any persistent health effects at that time. And now we're currently in the second follow-up phase of the study, where we're calling individuals again. This started earlier this year and is ongoing. So who's eligible to participate in the health study? And so we're interested in workers, but that is kind of a very broad definition. And so we looked at adults who've worked at least one day in oil spill response and cleanup activities, or took the safety training but were not hired. And so we recruited them from the training and workshop records provided by BP and other federal agencies. So Coast Guard members, I think the Admiral sent email to everybody in the Coast Guard and to looking for volunteers to participate in the study. And then also all folks who badged in and badged out through the TRG, the response group had maintained a record of people going in and out of work sites. We looked at those lists, all the training and safety records and such, and then try to merge and cull these different lists to identify individuals, and then mailed out these invitation letters, brochures, and privacy statements to get them to participate. And then we telephoned them to try to complete an enrollment telephone questionnaire. However, we discovered as we were getting underway that certain segments of the population were not included. So for instance, rig workers didn't have to badge in through TRG. They just went to the different heliports and badged in through their TWIC cards. And so we made some special efforts to try to recruit, increase enrollment within these high priority groups, because as you can imagine, the rig workers are in the hot zone at the wellhead, and so they were probably exposed to some of the highest levels, but they weren't in these lists that we had. And so we stationed an individual hanging out at the PHI heliport just down the road in Homa for a year, recruiting individuals as they were coming on and off the rigs, flying in and on and off those helicopters, to try to increase the amount of rig workers that were as part of our study. And then also special efforts to enroll Spanish and Vietnamese speakers who had participated in the VU, the Vessels of Opportunity program as well. So as you can see, this is a map of all the study participants. We enrolled over 32,000 adults between 2011 and 2013. And all 50 states are represented within our study. But you can see the large majority of the individuals are concentrated within the Gulf Coast region. As you can see, just pulling out just the 5 Gulf states, that the large majority of those individuals are within the 5 Gulf states as well. So the enrollment questionnaire, it consisted of a telephone interview that was very structured, between 30 and 60 minutes, both in English and in Spanish. Asking for a variety of demographic and socioeconomic factors, looking at different lifestyles, looking at what they did during the oil spill response and cleanup. So there's not actually a good record in terms of what they did, and also when they did it, because as you may or may not know, depending on the local weather patterns and the waves, what washed ashore, if you're a beach cleanup worker on a Monday versus on a Wednesday, for instance, that if the oil didn't wash ashore on Monday, your exposures were pretty low as compared to 2 days later when the wind directions change or something and then you're inundated. It's very, very different for folks on land as opposed to the individuals who are in the hot zone or on the water. Any medical conditions and symptoms that they may have experienced at the time of the spill and also at the time of enrollment. And then we also did an abbreviated questionnaire for the Vietnamese population to look at those individuals who participated. So in the end, we enrolled over 77% of the individuals were defined as oil spill cleanup workers, in that they had participated in one of these different categories. So response work and actively trying to stop the leak or drill the relief wells. So on the Enterprise, the DD2, DD3, the Q4000, those are the 4 main vessels that were in the hot zone throughout the duration of the spill. And then if they were in operations, where they involved in cleanup on the water, on the beaches, marshes, and shoreline structures, whether that they're doing decon or they're just doing support work, so working security, food service, logistics, supply chain, things like that. So that we have a variety of potential exposure levels for these individuals across our population, and 23% of them are non-workers. So for instance, those who had participated in the training, but just were not hired for one reason or another to participate in the cleanup. So you can see the different characteristics of the cohort between the English and Spanish speakers and the Vietnamese. And so the Vietnamese were an older population, and generally most of them had not worked in the cleanup as much. And so we focus our analyses here just on the English and Spanish population, but amongst the almost 1,000 Vietnamese workers, we reserve them aside for more a special study to look at those in more depth. But I'm not presenting those results among the Vietnamese at this time. So we did, in addition to the telephone enrollment, a smaller subset of individuals within the 5 Gulf states participate in a home visit, which consisted of approximately a 3-hour visit by a trained certified medical assistant. And so there, we collected a biologic sample from these individuals, we collected dust wipes from their home, we geocoded their residential address, looked at lung function and blood pressure, and then conducted additional questionnaire information to gather personal and family medical history, their mental health status, and then resident and occupational history and lifestyle characteristics to kind of better define, any potential health effects that occurred at the time. And then we've also provided reports back to participants and their medical providers if they wanted us to, and then provided medical referrals to federally qualified health centers within the area if they needed immediate medical attention. So amongst the home visit participants, we focused on the 5 Gulf states. We enrolled almost over 11,000 individuals who are participants in the home visit between May of 2011 and May of 2013. And so you can see that it's mainly concentrated in the Houston-Galveston area, the New Orleans, and also in Lafourche and Terrebonne parishes that I think had the most amount of individuals. And then in Mississippi and then Mobile and the Florida Panhandle, the Pensacola area. But we also had a large majority in the Miami-Dade County area as well. So to try to characterize the different oil spill exposures, it was a variety of experiences that we looked at that defined exposures, not just exposure to the oils and dispersants, but also from the flaring and burning of the oil to these large smoke plumes that were generated, but also the physiological and physical stressors, so job strain, long hours, heat stress, what had occurred during the oil spill response to cleanup, but also some traumatic experiences of seeing or smelling the oil, observing the flaring, job loss and worry about the future, residential exposures to different chemicals and other stressors. And we also acknowledge that some exposures are both chemical and stressful. Some of the work-related exposure measures that we used to define exposures was, did they work at least 1 day on the oil spill response to cleanup? The duration of the work. When did they work? Did they work early on in the response when oil was free-flowing, or was it later on when the well had already been top capped? Where did they work? So we're on the water, near shore, on land, on a rig, barge, or vessel or marsh. And some unique exposures that were defined by location and timing. So we got all the records in terms of all the aerial dispersant spraying, and then also on the marine dispersant spraying as well, where that occurred, and tried to geocode based on these patterns and where they reported they had occurred to try to match that up in terms of exposures. And we have a team of industrial hygienists that try to estimate those exposures to those individuals at the time of the response. And then also just more categorically, just looking at the type of work that they said that they did. So whether or not they were response and cleanup, operations, cleanup on land, whether they were doing decon or support work. So specifically, I think there was a lot of interest in looking at dispersants, whether or not the dispersants cause any health effects. So I'm going to focus the rest of my talk on the dispersants, but there's a large number of other studies, as you can imagine, that we've been also looking at in terms of exposures. But the amount of dispersants that were applied during this response was unprecedented. There was about 1.8 million gallons of Corexit 9500, 9527. There's 2 different types of dispersants that were used in response to the cleanup. The main chemicals of concern within these 2 dispersants was 2-butoxyethanol, propylene glycol, and petroleum distillates. And you can see kind of the breakdown between the 9527 and 9500. Corexit 9527 may be more acutely toxic, but some of the reported adverse effects were similar between the 2 dispersants. So, excuse me. So the previous studies of dispersants have focused mainly on the efficacy and effects on marine life, and there was very little human health data. So much of the toxicological and in vitro studies suggested the potential acute respiratory effects, and eye irritation. So we focus on that in our analysis to kind of look at these, whether or not these had occurred. And this was published in a paper in the Environmental Health Perspectives in 2017, McGowan et al. So the objectives of this analysis was looking at did the associations between self-reported respiratory and eye irritation symptoms at the time of the spill correlate to response and exposures during Deepwater Horizon, and then also determine if these persistence last. So did you have effects at the time of the spill, or and then did they keep occurring, or did they persist over time when we started collecting the data 1 to 3 years after the fact? So some of the outcomes of interest is that did you have these symptoms at the time of the spill, or within the past 30 days of the enrollment interview, which occurred 1 to 3 years afterwards. So we focused on respiratory symptoms, so cough, wheezing, tightness in the chest, shortness of breath, burning in the nose, throat, or lungs, and then also looking at eye irritation symptoms, burning in the eyes, itchy eyes. So we just characterized dispersant exposure based on self-report. So did you answer yes to any one of 8 questions about dispersant-related activities, or 1 or 3 questions about performing maintenance and tasks on equipment that held dispersants, so connecting lines, cleaning out tanks and whatnot. But also, did you personally spray dispersants? Did you handle dispersants on land or apply it on vessels, on working on pumps and connecting lines and things like that? So how do we distinguish between 9527 and 9500 exposure? And so we classified them as likely exposed to 9500 or potentially exposed to 9527 based on the reported timing of when they worked on their oil spill response. So before May 23rd of 2010, both 9527 and 9500A were used as part of the response efforts. And then twice as much of this was used before May 23rd. But then after May 23rd, until after the well was top cap, only 9500A was used. And so depending on when they reported that they worked, some people had worked starting in May of that year, and other people weren't even hired until August or afterwards. And so based on when they reported they had worked, we can try to triangulate whether or not they're exposed to both 9527 and 9500 or just 9500. And then we know that only correction 9500 was used at the wellhead. It was pumped into the plume as it was coming out of the wellhead. And then 9527 was only used in aerial applications. And then there was no aerial spraying within 5 nautical miles of the wellhead itself. And so this is a chart of a display of some of the results of the study. And so this is an adjusted prevalence ratio. So a prevalence ratio is basically comparing individuals who reported having these symptoms to those who did not report having it. And adjusted means that we controlled for these different variables. So for gender, we controlled based on age, race, gender, education, smoking, use of decon chemicals, pre-existing lung disease, level of oil exposure, the total hydrocarbons they're exposed to. And so we try to control for all these different other factors. And so ultimately, just comparing one-to-one, whether or not, if they worked on the spill or not, and then whether or not they have these symptoms. And so this is dispersant use and self-reported symptoms at the time of the spill. So do they have cough, wheeze, tightness in the chest, shortness of breath, or burning in the nose, throat, or lungs, burning eyes and itchy eyes? And so you can see that those who had reported working on the spill versus not, about 35% higher report having cough than those who did not. Wheezes was 28% higher. So 1.0 is basically having no effect at all. So it's just even. So compared with workers and not workers, it's just completely even. So if it's below 1, then it's preventive, and then above 1, we decide that it is associated with having worked on the spill. And so 44% of more people worked as well report burning in the nose, throat, or lungs, and then burning in GI. So we were really concerned that if people had worked on the spill, that they just said yes to everything. It's like, yeah, I got that, I got that, I got that. So just a checklist down. And so we put some dummy questions into the questionnaire just to So just to kind of just catch them and say, hey, like you just said yes to everything, and try to illuminate those individuals. But we looked at excessive and unusual hair loss, and you can see that that's not really related. Oh, these little box and whisker pluses are 95% confidence interval. So it's like if you have repeated the study 100 times, 95% of the time they'll appear within this range. And so you can see that hair loss is not a significant finding. So it leads us to some confidence that these results are real, that it really is occurring. And so this is within the past 30 days. You can see that. So this is at the time. These are the results at the time of the spill, and then within the past 30 days, you can see the results did go down. And so you can see that some of it had resolved over time. So the coughing had gone down only 6%, and then the 95% confidence interval does cross over 1.0, so that means it's not statistically significant. But wheeze is still elevated, tightness in chest, shortness of breath, burning in those sort of lungs, those are still elevated at the time, but not as high as during the spill. So some of it had resolved for some individuals, and it had gone down over time, so which is heartening to see. But we're still concerned that it was still high. And so we looked at those individuals who did report having symptoms at the time of the spill. So what happened to those people who said, yes, I did have health effects at the time of the spill, and now do those individuals still have it within the past 30 days of enrollment, 1 to 3 years after the fact? And you can see amongst those individuals that they did not have. So these findings here are all not significant. And so you can see that because they all cross over 1.0, that much for those individuals, they did resolve. And so what we're seeing here, that these elevations are new effects, that they had occurred, that people who reported that I did not have it at the time of the spill, but now all of a sudden I do have it. So that was kind of unusual finding for us, that we can't, that they didn't have it and then persist. That some of these are new reports. And so looking at Corexit use and respiratory symptoms at the time of the spill, looking at the difference between Corexit 9500A and 9527. So the circles are the effects from 9500 versus 9527A. You can see that 9527A seemed to be a little more toxic in these individuals, that they had reported higher prevalence of these symptoms at the time of the spill. So basically, it may differ in terms of what was used at the time. So in conclusion, in terms of the health studies, is that the dispersant use was associated with both respiratory symptoms and irritations at the time of the spill. There's slightly higher rates of symptoms associated with possible use of 9527A, but it could be also because due to the great amounts of dispersants that were used. Over 2/3 of the dispersants that were used, amount of dispersants that were used over the course of response was applied before May 23rd. But then the symptoms associated with dispersant use appear to resolve over time. But like I mentioned, the dispersant use of individuals who did not have it at the time of the spill, but then had it at enrollment 1 to 3 years later, was a little unusual. And so it is the GuLF long-term follow-up study, and so it's designed to address these different gaps in knowledge in the medical literature about what is known about health effects and oil spills. And so it's designed to answer questions that really matter to the workers and communities. So some of these can't be answered short term. And so do these symptoms persist? Do you still have these effects 8 years afterwards? Are there late effects? Do these cause cancer? Or mortality? Do people die from these things? And so we don't know this, and so that's why we're still involved in this effort 8 years after the fact to try to answer some of these questions that of concern, because a lot of times these diseases take a long time to develop, and so you don't have them, or you don't see these effects right off the bat. So for the next 5 years, we're engaged in cohort maintenance and retention, so basically communicating with GuLF study participants through newsletters and mailings to stay connected, update their addresses as they move, and to update their contact information and report back findings from the study. And also conducting passive follow-up for mortality and cancer incidents, and these all reported in the national registers. And so we work with the different states and to try to determine what happened to these individuals over time. And then we're also collecting a second follow-up interview. So if you're a GuLF study participant, we're trying to reach out to you now to get you to answer some questions like how is your health doing now, what has happened to you since our last contact information, to try to collect current information and then try to report back to these individuals what we find. As I mentioned, I had just focused on this one paper looking at dispersants and health effects, but you can see that there's additional findings that we have found. So for instance, we published in the Lancet on mental health impacts, so workers were more likely to have severe PTSD and depression, looking at respiratory health effects, so we did a spirometry effect looking at lung function, and they were reduced amongst decon workers and those exposed to burning oil. So these are the first authors of the studies, and these are the publications and when they were published. And you can see a bunch of them came out earlier this year, looking at non-fatal heart attacks, lung function. This is a coronary heart disease, and so there's a variety of different health outcomes that we've been able to look at. So some of the future directions of the study, we're looking at mental health service utilization, mental health outcomes, looking at patterns of change, looking at neurological health effects, and both central nervous system and peripheral nervous system, and then also looking at respiratory changes, any longitudinal changes in lung function as they relate to total hydrocarbon exposure, job exposures, and dispersants as well. So there's a lot of interest in it, and we're still ongoing. This is the study team. This is led by Dale Sandler, who's the principal investigator of the study, and then a variety of investigators around the country have helped us immensely. And you can find out more information about GuLF study here on this website. So I think I'm out of time, and I'll be available at the panel for answering any questions that you may have. Thank you so much.